Hi, welcome back. This week we're going to jump in and start talking about structural components. We'll start with basic deployment. My friend Jonathan Washko, who actually had the opportunity to do an internship with Jack Stout, who's considered by many to be the father of system status management, has actually derived something he calls the EMS System Success Triad. And in Jonathan's model, he implicates that there's three essential components to thinking about the design of an EMS system. We have to take the patient care into consideration, we have to take economic stability into consideration, and employee well-being. Well, I think there's one additional element that's missing from the triad, and that's actually customer satisfaction. And we'll look at how customer satisfaction actually plays a role in deployment systems, especially in the second week of deployment. So let's start by looking at these three components. Let's look at patient outcomes. It's pretty clear if we look at something like cardiac arrest and cardiac resuscitation rates that there's definitely a connection between response times and cardiac arrest survival rates. This study by Peter Pons in Denver actually looked at survival rates and response times and found that the survival benefit really is only prominent when the response time is less than 4 minutes. If you think about the average paramedic response in an ambulance, there's very few ambulances that have the capability to respond within 4 minutes. A paramedic response time within 8 minutes was not associated with improved survival of hospital discharge. Now, that is the case, especially if there's an early response by a first responder beforehand. A recent study supported this literature and reported that the addition of advanced life support procedures did not improve patient survival from cardiac arrest beyond that of rapid defibrillation. Now, in the last year or so, we're starting to see some additional studies that are coming on board, and actually some taking place here in the state of North Carolina, at places like Wake EMS, where they're looking at the impact of paramedics and the additional skills that they can bring to the scene and how that impacts cardiac resuscitation. But it's important to keep these studies in mind because there's a clear connection between basic life support and survival, especially if you consider defibrillation part of basic life support. Here's a second study that was actually done by Tom Blackwell here in Mecklenburg County in North Carolina. They looked at response time effectiveness and the comparison of response time and survival in an urban emergency medical service. And what they found is the mortality risk curve was generally flat over the response time interval exceeding 5 minutes. So once again, if we're looking at a response time longer than 4 to 5 minutes for advanced life support, there's definitely an additional component that is necessary, being first response. And we've talked about that as being an essential component of the overall system design, and we'll talk about it even more in weeks to come. But what about trauma? Well, definitely there's a relationship between early response to a call and trauma survivals. But again, it's the basic life support skills that seem to be the most impactful in these situations. So the important thing is to actually get someone to the patient as rapidly as possible. Now, I have to add in at this point, as part of system design, one of the discussions that usually comes up is around the concept of the golden hour. Unfortunately, to date, there's no literature that supports the concept of the golden hour. It does make sense, theoretically, that if you get a patient to a trauma center, and I'll use that terminology loosely, a medical center that has the capabilities to provide the care needed for a patient, that the probability of that patient's survival should seem to increase, but there's not a direct connection. The data from Maryland that supported the concept of the golden hour has never surfaced, has never been seen It was a theoretical concept that was utilized to sell the concept of an air medical program in the state of Maryland. And yes, if I'm involved in an accident and I have a penetrating or a blunt injury, I would like for you to transport me as fast as possible to an academic medical center with trauma facilities. But if we look at the studies, they're just not there to support the whole concept of the golden hour. So once again, we have to keep that in mind. And this is one of the reasons I feel like the customer satisfaction plays a role, is because customers do have this expectation from what they've heard over the last 30 years. So if you're interested in looking at the research related to the golden hour, I point you to Brooke Lerner's paper that was in Academic Emergency Medicine back in July of 2001, which she actually took and looked at all the literature. And again, her conclusion was that it remains unclear whether objective data exists to support the concept of the golden hour. Now, back up one slide, there is a relationship between total pre-hospital time and outcome and hypotensive penetrating trauma injuries. In these patients, it's very clear that if you can get them to the surgical suite fast enough, there's the possibility of surgical intervention that could be life-saving. So definitely these patients, there definitely is research to support designing a system around these patients if you're in a system that has a high number of penetrating injuries. Well, what about economic stability? Well, from an economic stability perspective, there are a lot of things that play in to the cost and our ability to design an EMS response system that is economically sound. A lot of the things that influence that are the things you see here that Jack Stout actually called the Stout Curve. And basically it says that the response time requirements, artificial production, we'll talk more about that, constraints, those are things such as a political demand that an ambulance be placed in a certain location that may not be the most appropriate location for optimal operation of the system. You see that very often where a small community may even generate funds to support the housing of an EMS unit or an ambulance more specifically, and when that happens they expect an ambulance to be stationed in that facility. Unfortunately, that may be a very inappropriate location for that ambulance in terms of overall system response. So that'll become more clear as we move forward. Call density, definitely the more geography you have and the less volume, the more difficulty in coverage. Economies of scale definitely play a role that we talked about in the previous lecture. Mutual aid, whether we both are willing to provide mutual aid and whether mutual aid is available to assist us in high demand times. Traffic patterns definitely play a role. Demand patterns play a role. Sometimes in some locations you'll see demand patterns change drastically between times of the day. And there's definitely many more things that'll come into play as we keep talking about the deployment system. Response time determination, we really have to look at all of these factors. We have to look at the demographics. We have to look at the specifications in terms of what is required. In some locations, I had the opportunity to do a good bit of work in Canada. There's actually a mandated in the province of Ontario, there's actually a mandate for a particular response time within a given geographical area. Ironically, that demanded specified response time is based on a historical response time at a given point in time when they said that the mark will start today. What is your response time? And then they created somewhat of a challenge for that. So it's not uniform across province, but it is a specified response time. Definitely, if you're in a location that has a contractual requirement to respond within a given period of time, you have specifications related to that, and you're seeing that more and more in different communities. Customer satisfaction, as I said, definitely plays a role. The customer has a high expectation for EMS today, much higher expectation today than they did years ago, and that's in large part due to TV shows and movies that have aired over the last 20 years that have really pointed out the impact of EMS and the importance of early response. And then, of course, clinical outcomes does play a role. So you should consider that and consider the latest research in designing an EMS system. Well, over the last several years, we've actually developed something called the deployment curve. And as you see here, the deployment curve, the back end of the calculations, some people say, can you just tell me how to calculate this? It's very difficult because there's a lot of nonlinear equations that go in to a computer simulation process to develop this. But the output that you see here, the demand curve, actually shows a period from 1 o'clock to 8 o'clock coverage. And it shows what amount of coverage can be provided by a certain number of vehicles. What we've come to realize is that the appropriate place on this deployment curve is really dependent on several factors. It's dependent on customer satisfaction and the customer expectations. It's dependent on clinical outcomes and what a community feels the clinical outcomes are that they actually want, and how they interpret the literature. And thirdly, and most importantly, it's dependent, as we saw on the very first slide, on the economic ability of a given location. So if you took those three things into consideration and looked at it, then there would be some tangent on this curve that would be the best option for any given community. But the key phrase there, or the key point there, is that there's one spot on this demand curve that's appropriate for any one given location based on their demographics, their geography, their response capability, their roadways. All of those factors play into this simulation, and each community, that would be different. So in essence, each community would need to evaluate it in this manner. You see here, this community decided that the desired point for this given community was 21 ambulances. Let me point out one more thing while we're talking about the deployment curve. Notice how over time there's diminishing marginal return. That's just another way of saying, as I go from 1 to 2 ambulances to 3 to 4, as I increase the number of ambulances, you start seeing a marginal decrease, a small decrease in the amount of coverage increase that's provided by adding that one additional ambulance, such that if you get past 21 ambulances up to about, let's look around ambulance 30. If you take and you draw a vertical line straight up to ambulance 30, you see that as I go from ambulance 30 to 31, there's very little benefit in terms of coverage and response time capability, or improvement in response time capability. So it doesn't make a lot of economical sense to go from 30 to 31 unless there's some other factor that's responsible for you adding that ambulance, such as employee well-being, where maybe that you're over-utilizing the personnel at 30 ambulances, and you're trying to add a few more unit hours to actually offset that. That would be the only reason that you would want to go from 30 to 31. Well, definitely all these factors play into employee well-being, and we'll keep that in mind as we move forward in talking about it, because it definitely is an important factor. It's actually been studied in a few organizations. One particular organization has found that when the unit hour utilization gets beyond 0.48, which is almost transporting one patient every 2 hours that the EMS crew is on staff or actually on the ambulance responding to calls. When it gets that high, you start seeing a decrease in morale of personnel and start seeing employee issues. So definitely that is something to keep in mind and thinking about keeping your unit hour utilization below that. Just another point, since we're talking about unit hour utilization. Again, we'll come back to it and talk about it in more depth, but unit hour utilization is simply, and this should have been in the readings from last week about public utility models, unit hour utilization is one ambulance staffed 1 hour. So that's 2 crew members at least and an ambulance that can respond to a call. When we look at utilization, we look at how much of that time that ambulance staff with 2 people is actually utilized. So again, if it's 0.5 or 50% utilization, that means for a 12-hour shift, the crew would transport 6 patients. And it's based on transport of patients because historically, that's what's tied to revenue. That's what generates income for the system or revenue for the system to actually be able to help keep it sustainable. So it's important to think about that. So in thinking about unit hour utilization, all of these other factors also play a key role. They play a key role in retention, health and safety, satisfaction to the crews, the scheduling capability. It could be that you have swinging pendulums and hot spots throughout the 24-hour shift that you need a much larger number of ambulances, and when you do that, it definitely is going to conflict in terms of scheduling with employees of being able to schedule them for one set amount of time. So in that regard, what we'll see when we talk about scheduling next week is that the more flexibility you have in terms of scheduling, the better you can match supply to demand, which is our overall objective. The work environment is definitely going to play a role. Again, working in places like Canada, it's very cold in the winter, so definitely that plays a role in the crews, just like an environment that would be very hot would do the same thing. Compensation is definitely an issue. It's going to play in, and we'll see how that plays in, probably specifically in the EMS Finance course, where we'll talk about the connection between the employees and the work schedules and how that actually influences overall system design. We'll push back into the content from this course. Recruitment, some places that have very dynamic systems that have very finely tuned matching of supply and demand, they have difficulty in recruiting employees for work, which actually is really sad because it actually makes it much more complicated on the employees they do have, because they end up working overtime to meet response time requirements and end up working a lot of mandatory overtime, which at first they like because of the financial gains that are associated with that. But in the long term, it takes an effect on the next issue on the list, which is family and retention and health and safety and satisfaction. So definitely all those pieces play a role. Well, let's talk about basic deployment models just for a moment. And let's look at the difference between the EMS function and the fire function in terms of deployment systems. If we look at fire response, we start out with a given number of fire stations usually. When a fire exists or is reported, a fire truck responds, or engine company, or whatever the case might be, a fire response is initiated. They respond to the call. Hopefully, they're able to extinguish the fire, and they respond back to their initial location. Another fire is reported. There's a fire response and a return to station. Now, when we talk about ambulance response, though, the scenario is a little different. let's say that we have, you can call these EMS stations or posts, but we'll start out and we'll say we have three stations, three EMS stations. A car accident's reported. An ambulance responds. That ambulance needs to transport the patient to the hospital. A transport's initiated. Well, as you notice, the whole northern half of this community is left uncovered at this point in time. So, quite often what happens is one of the ambulances, in this scenario from post 3 or station 3, is moved to an artificial location. It could be a physical location, such as another station. It could be a street corner. It could be any combination of things in between that, on a pendulum or on a scale. Once the ambulance clears the hospital, you see that another wreck takes place. Well, the ambulance from the post responds to the accident. The ambulance from the hospital, now the best location for them would be in station 3 or post 3, because the whole the northeast side of the community now is left uncovered. So it actually responds from the hospital to post 3, and then to the hospital. And then you see there's this continuous movement in the system. It's very dynamic in the context of the way responses actually arise. So that's an important factor, because it's very different than this model, where in the fire station model or the static deployment model, you go to a location of an incident and then you respond back to the initial location. So there's also some other differences about the fire model. The fire departments operate under a more unified command and control structure than EMS does, and that's appropriate in a lot of scenarios, because you have a larger number of employees, firefighters, responding to an incident. They respond to the incident. There could be multiple resources that are responding to that incident. Someone needs to be in command or have oversight of what's taking place in that total operation. And that system works very well for the fire operation. They respond to nearby locations. Again, upon completing, they return back to their station. And fires affect buildings for the largest extent, even though a lot of fire services now provide first response to medical calls. Fires, for the most, all practical purposes, happen in buildings. So buildings don't move around, so they're stationary. So there's not a lot of flux that takes place in terms of fire deployment. On the other hand, as we saw with EMS deployment, there's a lot of flux that takes place. EMS crews operate in a more independent manner than fire crews. Usually it's 2 personnel responding in an ambulance to a call. They're responsible for each other for, oversight of that patient. One person may take the lead. There may be a senior person on that ambulance, but it's a very different situation in terms of command and control than the fire responses we saw, where there's multiple personnel at a given incident. The EMS response, again, is more fluid, more highly correlated with movement of people, as opposed to the fire response to buildings. The EMS response requires less human resources and less expensive equipment. And most EMS responses are not time critical from the patient's outcome perspective, which is not it's not the mode that we normally think about in terms of ambulance deployment. We think in terms of responding in a critical scenario in a very short order of time. But remember the study that we saw, the Peter Pond study, that said that we need to respond within less than 4 minutes to have that major impact. And that was reiterated by the Tom Blackwell study from Mecklenburg County, that said it needs to be in less than 5 minutes. So there's a combination of things that we need here in terms of deployment. So I'm going to stop there for this lecture. We'll pick up in the next lecture and start talking specifically about how to think about designing these different type EMS deployment systems.